The first thing to say is that we know from both animal and human studies that microorganisms are essential for the development of apical periodontitis.
I would buy that if you think that radiolucency is what we call a perfect surrogate of the clinical outcome. And I know no medical discipline that has perfect surrogates of the clinical outcome. A perfect surrogate is not just a strong correlate of the outcome, which means a strong risk factor, it's also a strong correlate of the treatment response, which means that every single patient who has reduced radiolucency will do great. And every single patient who does not have reduced radiolucency will do bad. Do you have that? I mean, if you have that, then this is the first time that I see a perfect surrogate, and I can take it and say that then you have an answer. You don't need randomization. Instead of looking at other outcomes, you just look at radiolucency.
But the important thing is that every time I do this, she will pick up the instrument. Once I feel I'm not looking at her, I will open up my hand, and she's not going to drag the instrument. She's going to remove the instrument.
What's messy about this is that if you're chronically stressed, some people say, I'm so stressed I can't eat. And that's because the catecholamine response is actually an appetite suppressant. But then there's other people with the same stress. I feel chronically stressed, and they're eating the house. So it's like, well, how you can stress and have these completely opposite effects? And some of it is because of the signature of your particular type of stress, and that gets messy. But this is an example of why it's difficult.
What is the process we're talking about? And these are some pretty simple rules, but they're really important rules, and it's fine if you want to take a screenshot of this, because these, you really need to commit these to memory. First of all, you develop keystone habits. Everything we do is based on what's called a keystone habit.
And this is covered in the CBCT text, but we are the ordering, interpreting, and intervening clinician. And this is really different than medicine, especially when it comes to advanced imaging. The radiologist does not have any horse in that race. And we do, in a sense. We see things see things at imaging, and we feel, shall we say, compelled to intervene. And the radiologist doesn't have that same emotional loading when they look at the imaging. The other thing we do, too, is we look at imaging and we don't describe imaging the same way that medical radiologists describe it. And there's a reason medical radiology is a 4-year specialty straight away, and then there are subspecialties after that. And we don't get that same kind of training. And so when I watch endodontists talk about imaging and report imaging findings, they use very loaded language. And let's again talk about that later.
And as we've been learning over the years, we have to think more globally, even beyond teeth, beyond root canal treatment, even beyond restorations. You know, why are these teeth cracking in the first place? And many times they're due to parafunctional habits that are related to myofascial pain and also disrupted sleep and allostatic load, as Drs. Rahim Karmali and Rob Kaur have been studying and have been educating us on over the past several years.
And basically, the training process is based on details and repetition. So first of all, we want to explain the process that we're doing and all the details. We demonstrate the practice and practice it. We repeat the skill 1,000 times until it's totally automatic. And we will review every skill until the end, from day one, to make sure that every skill is being done the best way possible. So we will first get the assistants together, we will gather them, we will go through the basic setup. My recommendation when you prepare your surgical tray is that you try always not to have too many instruments. I can assure you that 95% of your surgeries, you always use the same instruments. I sometimes see some surgical trays where I see 15 retractors, 10 different kind of curettes. And you think, well, how many of those are you using? Basically, what you're making, or what's happening is that you are confusing your team.
So inference is a conclusion based on evidence and reasoning, and we're trying to develop a theory of a mechanism based on the information collected. So in what we do in endodontics, we gather data from a sample of the population, and we use that set of information to make inferences on the broader population. So we also create population models for the details of the subjects that we sample. So a model is a description of a system, in this case of a data generating process. It's a formal representation of a theory. So the two main types of inference, the first is the classical or the frequentist type. This is very common. It relates to the plausibility of propositions, otherwise called a hypothesis, using repeated sampling of a population distribution. So as you repeat the same task over and over again, like flipping a coin or rolling a die, or sampling the population over and over. And this is the plausibility if you kept on collecting data repeatedly. The other type, the Bayesian paradigm. So this is Thomas Bayes, English reverend in the 1700s. This paradigm refers to the degree of belief, using probability language as the basis for making propositions or inferences. And probability is the degree of belief that an event is true. And in particular with Bayesian inference, conditional probability is the updated probability given that another event has already occurred, so conditional upon another event. So what follows from an inference paradigm is the type of reasoning. Deductive reasoning will start with a theory.
Today I want to talk a little about resorption and hopefully untangle it a little bit. This is Shinryu Suzuki Roshi. He was a Zen master. He passed away in 1971. He was instrumental in bringing Zen Buddhism to the United States in the 50s and 60s. And he's got a great book that he's written that's very foundational, and it's called Zen Mind, Beginner's Mind. And in this book, he opens with this quote: "In the beginner's mind, there are many possibilities. In the expert's mind, there are few." The beginner's mind, many possibilities. In an expert's mind, a few. When it comes to resorption, it's kind of a tangled topic. And with resorption, there are actually very few experts, right? Partly because we don't have a tremendous knowledge base on endodontics, right? Most of the literature we have on resorption deals with describing the resorption microscopically, histologically, with nano-CT, and it deals with categorizing the resorption.
So 99% of the people who answered the survey thought they were above average. So I put that in there, just the idea that don't delude yourself about how great you are. You know, when you work in your office and you might have a bunch of women working for you telling you how great you are. Of course, your spouse doesn't necessarily tell you that, but be critical of yourself. Because if you're not, you'll never grow as a person or a professional. You'll be one of these 9 to 5 people that does everything the way they learned in residency. And when you fail, just don't give up. Push ahead, and you'll still be able to achieve most of your goals. So Gary says this sometimes, but I looked it up, and it's actually the Dalai Lama was the original person who said this, according to Wikipedia anyway. When you lose, don't lose the lesson.
Address what Rick was saying about the patients, about how people have a double standard. The cases that Rick has shown, and I want to actually expand on that, are single tooth cases. We have no problem with rolling dice on single tooth cases, whether it's a family member or not a family member. But when an endodontic treated tooth can affect a reconstruction, and that means a segment, not just the whole mouth, then it's an issue. And there we become very aggressive. So I will tell you, in general, when I am not placing implants, or it's just one tooth involved, I'm actually pretty conservative. You can ask the endodontists that I work with. But once I start placing implants in a segment, the question is, why do I need the teeth in the long term? What is a stronger unit that can support my restoration? Okay, so
I take a Stropco, we dry it out, and if you were able to achieve adequate hemostatic control, and your chair side is working with you within the microscope, and you use some local hemostatic agents, this is how well you'd be able to see, using a micromirror inside the root canal, the other side of the cast post. So now you're actually ready to fill the root canal you just surgerized. Okay, suturing. What is their armamentarium? Microscope itself doesn't open any gates to paradise, even if a wrong armamentarium is used. As an example, a well-manufactured Matthew or Heger type retractor would put the entire surgical procedure under stress due to the design, weight, and cremallear tooth rack lock. So it's not suitable for microsurgery. So a microsurgical needle holder has to be round-bodied in its cross-section, has to be light, titanium preferably. The lock has to be present with a spring, because with only one single move of your index and thumb finger, you'd be able to open and close the jaws of the needle holder once your suture tail needs to be once your needle needs to be recatched or your suture tail needs to be grasped. Because the cremallear tooth rack lock would put the entire surgical procedure into stress, because your hand will have to go through the entire cycle of this teeth going in between each other. The jaws of a needle holder should be diamond coated. They should be thin, because once you use your finer suturing, like say 8-0 or 9-0 sutures, the thinner the jaws, the better you have ability to catch it once this needle is stuck in between teeth proximals. Same thing should be applied to the tissue forceps. It should be round-bodied in its cross-section, and like I said, I use a lot of instruments, and these are the instruments I use now, especially for tying the knot stage. These instruments are titanium. They're actually manufactured in my country, and the thicker the instrument, the better the ability you have to rotate this instrument within the surgical field. You had a better control, you got a better tactile control, because the problem with suturing sometimes what you have is unconsciousness movement, because we don't know where our hands are. And I'll try.
Made some progression. Shimon's group looked at some of these bench studies, and they seem to find retaining some of this tooth structure may have some value. Finally, we are making some progress here. So overall, what's the summary? Removing tooth structure makes it weaker. Critical tooth structure makes it a lot weaker. So what exactly is the critical tooth structure? So I'm kind of visual, so I'm going to go through some of the pictures, which actually I did myself. And I took a tooth, I shaved it off. As an endodontist, I was well trained to address this area at the roots. As a general dentist, I always concentrated here, right here. But what I also realized, some of the finest restorative dentists, they always looked at this area. If you look at the restorative literature, every time they go back and point out to the amount of tooth structure which is left at the cervical area.
But my fourth take-home point is that I think the way forward for your specialty is actually not to have individual academic centers start to do better trials. That would be nice, it would be useful, but I don't think that's going to be the paradigm shifting thing. I think you have a remarkably vibrant academic, intellectual, and clinical community, and what you really need to figure out is if you have the personal fortitude and tolerance and willingness to do volunteer work on behalf of future patients, which is what it is, to create a practice-based research network and use the software that you share in order to allow yourself to actually randomize patients among therapies, some of which you wouldn't personally recommend, but for which there's enough uncertainty in the community to make randomization ethical. and then follow those outcomes so that a year from now or 2 years or 3 years from now, instead of talking about the same controversies, you talk about, wow, we learned that this choice doesn't matter because the outcomes are similar enough, or this choice does matter. And then your conversation at your scientific assembly could be about what the next trial to do is. Because one thing that I would love to have you do is, instead of being the recipients of people talking to, at, or with you, depending on how you look at it, would be having a discussion where what we're all doing is working together to design
planet based on the anatomy of the tooth, if you want to make your access in a certain position or not. So the intraoral scanner I have is the iTero. You may be familiar with that. Several ones out, TrueShape, CareStream has one. But this is what it looks like after I've taken an impression with the digital scanner, and then that's laid over the CT. So let's look at one more. Let's look at a molar here. This is tooth number 30. And for this one, we're going to do 3 separate individual accesses. And I know, several people have been doing this on TDO freehand, but what I'm looking for is predictability. I've done some, they end up great. Other ones, you end up overshooting it one way or the other. Case ends up worse than traditional. So we're going in the distal canal here first. And again, like I said, getting started is the hardest part. You can kind of start the access close, and then you can move your handpiece live as you're drilling. And this one is going to be to a depth of 12 millimeters. So you have your depth and your angle there at top. So we're at 8. You can look over at the CT image on the right. You can see you're quickly approaching the canals on this case. And instead of right now, we don't have like mesial, distal, MB, implant names, so we're picking these 31, 30, and 29. And to me, it doesn't really matter which is which. I don't even have to know which one I'm drilling with at the time. I drill one, then my assistant will click over to the next implant. We're moving on here. And you can see that the MB and ML are actually crossing on this case due to the emergence of the canals. It's an implant. It's a one-to-one. It's a surgical. It's a one-to-one. Yeah. So it can go up to 50,000 RPM. I run it at about 2,000 to 4,000 RPM for this. I'm going through a porcelain crown. I'm using the electric high speed first, and then I switch over to this. Once you get into the dentin, you're fine. I was running it a little higher at first, and there's no water irrigation on this one, and so it was kind of heating up a little bit, so I found that lower speed is better. So we're in the ML canal now, tracking it. And 9, 10, I think we're going to 12 millimeters on this one. Not looking through the microscope. I'll show a video of that, but I'm looking at a screen when I do this. This screen right here that showed, this is positioned off the patient's left hip, and I'm sitting in my chair and I'm looking at that screen while I'm working.
That's what evidence is in a Bayesian context. And in some ways, that's more important than this business of prior odds. Really, it's this piece that's really different. It's how we measure evidence. And it's saying that evidence, you need 2 possible explanations, and you don't talk about the probability of something plus more extreme results. You just talk about the probability of what you saw, which is really interesting. That's observable. Everybody can agree on what you saw. They might not agree on lots of things, but they agree on what you can agree on, what you actually see.